continue on the adjuvant side. Is that something that would be appealing?
Like a MAGIC plus study, like a MAGIC type of study. But do you do that in Korea?
Yeah. I think MAGIC was chemo, right? The Cunningham thing.
Yes.
Yeah.
It's just pure antibodies. So non-cytotoxic induction. Oh. Okay. Or like a window study, you mean? Okay. As a pilot window study for your biopsies?
It may not be that common to do the neoadjuvant or perioperative chemotherapy for gastric cancer here, but it's common to do that for esophageal squamous cell carcinoma. The neoadjuvant chemoradiotherapy is actually the standard, MI standard.
But I think the new adjuvant setting will take a long time, because for esophageal cancer, the chemo combination with the radiotherapy, the response rate is very high. So if you over it will take more risk.
Shall we go to the next compound?
To the next indication now, or compound.
Excuse me, can I ask one question? So like you have some response patient in pancreatic cancer, but do you have any specific idea or strategy in pancreatic cancer, like NAC or adjuvant setting? No?
Do you mean the TAP?
Yeah, CHOP.
Oh. So for now, we are going to do a 30-patient expansion study, and we'll take a look at the signals there. I mean, you're right. We had that one patient with a PR, but who was MSI or who is MSI high. So it's hard to judge where the efficacy comes from. And okay, we had another patient who had that prolonged stabilization up to 6 months. But we would like first to see a couple of more signals in that expansion phase.
Then maybe a little bit different from the what you were talking about, but the gemcitabine plus nab-paclitaxel. So in Japanese patient, response rate is like 60%. That's surprising. So I think if you combine with gemcitabine with nab-paclitaxel in maybe neoadjuvant setting, that would be great. Maybe, and then there's possibility you have more synergistic effect in the setting in the future. But now we have many converted patients, and then even the patient. I have 3 patients having more than 10 metastatic liver tumors, and then after like 1 or 6 months gemcitabine with nab-paclitaxel therapy, they got converted and then we resected, and then they still alive after like 1 year. So maybe you have that possibility too.
I had one quick question before we move on to another possible combination. Wanted your opinion of is IL-17 blockade. What's your opinion on IL-17? I mean, there's now signals that have emerged from some of the trials by Roche, Genentech on inverse correlations between IL-17A and F and clinical response. And we do have an IL-17 nanobody that is very specific, very safe, and we're thinking of combining. What's your thoughts on IL-17 in gastric, as well as even in HCC as well?
Yes, very interesting. If I can, have a that drug, I will, do a very small study for, target immunodynamics. So I want to see what happens in tumors after that antibody first. So, for example, there may be some change in influx or efflux of T cells, macrophages and all other cells, including Tregs. Why not? So then I want to at the same time see the effect of a combination. But first, I want to see the change in the tumor.
Have the drugs entered the early phase trial?
It's not yet for oncology, but the drug was originally for psoriasis,
Yes.
for plaque psoriasis. But I think we have an opportunity here to also reposition the drug as an oncology IO combination.
Is it approved for psoriasis?
No,
No.
not yet.
Psoriasis and ankylosing spondylitis maybe,
Yeah.
so very interesting compound. It changed the T cell milieu, as I know.
Right. Yeah. That's something to consider.
Yeah, there's a competitive approved for cirrhosis and spondylitis.
okay.
Competitive approved.
Wasn't aware of that.
All right. Second compound.
Second one is TGF-beta. I just refresh everyone. Olaf already presented the slides before. So this is a general biomarker strategy at this moment for this compound. So we have two things to explore. The first one is PD, whether it's really hit the target TGF-beta and PD-1. Another one is about predictive biomarkers. So I'm not going to go to the details. So let's a little bit focus on potential another Asia phase 1/2 trial. So in this trial, we currently propose 2 biomarker sub-study for gastric cancer and esophageal cancer. Very similar design as HCC biomarker study. Maybe as Dr. Bang already mentioned, probably it's a little bit easier to do some kind of biopsy, pair biopsies in these 2 indications. So currently, we're just thinking 20, but we can discuss what is 20 or other number in the future. The general thinking is in the selected sites, we do pair biopsy. One is for gastric esophageal junction / gastric cancer cohort. Another one is esophageal cancer squamous histology. And once we identify certain evidence or confidence in potential predictive markers, we are going to discuss prospective validate those biomarkers. So the next one is our questions for these 2 cohorts. The very first cohort, the very first question is about differentiation. So in your opinion, would you think this kind of study valuable to give us information, help us to differentiate from our competitors?
As I said, you really need this kind of study to differentiate your compound from other agent. It is very, very important. But we have to think about many things. So this kind of study should be done in small number of selected centers, non-main centers. For example, if you take a biopsy, does it cause any change in tumor environment or not? So actually, just paired biopsy study is not, simple at all. So you have to think about, location of a biopsy. It can be very important. And another thing is TGF-beta level in blood. So actually, TGF-beta is very high in platelet. So it is very, very important to collect fresh frozen plasma if you want to see the, effect of TGF-beta level. Not easy.
Jürgen, you may comment. Didn't we try to do the TGF-beta atomicide assessment? And it was kind of difficult, technically, no? Or am I wrong?
So this confirms what was just said. Yeah, so this is indeed quite challenging due to the nature of that analytes we are looking at and technical aspects.
Any other opinions?
I have no any idea about it because we have not screened any information about the TGF-beta or another biomarker. But in 5 years ago, I used to do the phase 2 study, is the cetuximab with chemo. I found that the TGF-beta level is a relationship with the response rate. But the tissue is the tissue overexpression is very lower. It's about under 10%.
Just want to say this, that this type of research and activities are highly welcomed at my center. And my worry is still the number, the patient number. Still, 20 may be too small to get any firm conclusions.
And there is one rationale for the study in gastric cancer with this compound. There is a special subtype of gastric cancer called Squamous type gastric cancer, very poor prognosis, and it is associated with very high level of TGF-beta in plasma and tissue. So your compound may be more effective in those settings.
Say it again, please. What subtype?
Squamous type.
Okay.
Yeah.
Dr. Bang, do you have any idea of the preference of the KRAS subtype?
Strong fibrosis. It depends on the definition. Usually, Bowman type 4 can be, Squamous type is A.
Any other opinion? Highly recommend, welcome. Yeah, okay, maybe we can go to next one. It's about, again, I ask the question again, feasibility. So maybe 20 is not enough, then may I ask a question, within 1 year, how many patients can really attend this kind of paired biopsy or research study?
In the research setting, I think we can do that kind of studies. In fact, we just recently finished the studies, and we did paired esophageal cancer tissue biopsies about 2 weeks after initiating the first cycle of chemotherapies, and we can compare their PD-L1 expressions in the paired tissues before and after just one cycle of chemotherapies. And this, what we found are actually quite interesting. And we found that the PD-L1 expressions in both in the tumor cells and immune cells can go high significantly after the chemotherapies. But at this moment, we still don't know that the induced PD-L1 expression, whether they have any difference in terms of their prognosis significance or biologies compared with the baseline PD-L1 expressions.
Then would you expand how many patients, for example, if it's for such kind of paired biopsy, how many patients you probably can contribute within 1 year? Sorry.
If you are talking about my interest, actually is major in the esophageal cancers, and definitely I think we can contribute a lot of patients in that kind of trials. Okay.
Other key opinion leaders who have different thinking, or?
But I think it's also possible in all cancer centers, the pair, the biopsy. Yeah. So, but it depends on what trial we do. Yeah. So if there is a very exciting, attractive trial, the patient may, go follow the protocol.
Yeah, it's dependent on the need of the treatment. For gastric cancer, it's very promising to do the second or third time the biopsy because the lots of patients have a primary location because they lost the chance of the operation. But for esophageal cancer, because most patients with the squamous cell cancer, they will with a high risk of bleeding. So sometimes we will be more carefully to do the biopsy.
Yeah. So I probably can hand over to Maury. I'm not sure Maury will still have time to cover other tumor types.
Well, we have not so much time anymore, so if you believe that you can make it in 5 minutes.
5 minutes.
So today we talk about HCC, gastric, and not esophageal so much, right? But I think one of most interest in in context of Asian development is, as I show here, BTC, because compared to other indications which we discussed here, it's a much less competition, and there are several literatures saying the important role of tumor development in the BTC. So we have in this ongoing Asian study, we have a BTC cohort, and we are trying to take a very similar approach what we are doing like HCC. Because so far as I know, there are no second-line standard of care. So we might also consider like an accelerator approval in case we have very excellent data, followed by a pivotal study, hopefully aiming a first-line setting. So that's one of our priority, particularly in the current ongoing Asian study. So that's so far we are going to have 30 patients, and if we have some promising signal, we'd like to expand. So that's. But actually, if we do not find any particular signal, but many SDs like we saw in the HCC, we may conduct a controlled study. So that's the two different pathways we're considering to go for the second line setting. So, but I still quickly just, do you have any a promising compound which can be competitive for the development of second line BTC right now? Quickly, yeah. Are you aware any?
For second line therapy,
yeah.
I think many companies trying to get involved in IO, immune agent, and then I don't have good impression. And then also for first line therapy, they try to combine with the gemcitabine with cisplatin with immune agent. And then I think, like you said, there's no many competitors.
Okay.
That's good things. And then so, and then also you are trying to explore in second line setting, right?
Yes.
Not in first line setting.
Both actually, but I think we have for the first time only treat the second line patient to figure out how the activity look like as an initial approach. Yeah. So, okay, thank you. But so then, any other
Actually, last year, I presented the result of the keynote study in biliary cancer.
Yeah.
Number was around 20%.
Yes.
Response rate was approximately 15%.
Right.
I'd like to emphasize one thing. Actually, we enrolled 7 patients from our site. 3 patients had objective response, including 1 CR. So it is clear that some patients get benefit from PD-1 or PD-L1 antibodies. So if I were you, I'll do very quick signal-seeking studies, signal study. If there is a signal, then I will go to phase 3 for second line.
Second line?
Yes.
Okay.
So, for example, you can do it as a study comparing your compound versus S1 or something in control arm.
Can I ask one question,
Yes.
Dr. Bang? What type of biliary tract cancer was, so you said 3 responder, right? And then what type of biliary tract cancer was that?
As I remember, there was a patient with GB and extrahepatic, but my memory is not so good at this time.
because their characteristic is totally different. I mean, GB, they're easy to respond to chemotherapy, but prognosis is not so great. But in biliary tract cancer, they have longer survival, but they don't respond. So we need to think about that.
Yes.
So you mean to try both, like anyway, we include both, right? Anyway.
Yeah, because like number is not so
Right.
great.
Yeah. So far, as like a BTC, we just include and see how the tumor responds. Okay. And so, is there any particular, like, let's say, like overall response might be a good read at the initial? How much response do you think is promising? Yeah. I mean, yeah. I mean, percentage of response rate, actually.
Okay, so if you have a 20%, that's great.
That's great. Yeah. Yeah, 20% is good. Yeah. Then
Excellent.
20%, then you recommend to. Yeah. Very high. Okay. Good. Thank you. What else? Yeah. Okay, maybe that's all. Thank you. Yeah.
I have one question regarding the treatment flow. I saw data for biliary tract cancer that actually only about 50% of the patients undergo first-line chemotherapy in the advanced setting. What is the reason for that? Are the patients in too bad shape, or that they don't undergo chemotherapy?
I think that more patients in Asian centers in Japan and Korea receive, chemo than in Western countries. For example, after surgery, the interval of the CT scan is different among countries. Very, short interval in Japan, followed by in Korea, then longer interval in Europe, including UK and France. So patients present with bulky tumors, poor prognosis. It's one reason.
It's like in our country, it's like from 6 weeks to 8 weeks. But like in European countries, it will be like sometimes 4 months. So of course there's a big difference.
Yeah, most of the patients that I see, they have obstructive jaundice, they require multiple standings, PD-BD. It would be great if you can lower the bar for the inclusion criteria for the bilirubin level if your drug is safe. Otherwise, it would be so hard to enroll them.
Thank you very much. Yeah. Yep.
Thanks, Maury.
I wanted to thank you all for coming today to help us really with your support, but also your critical comments here on our programs. I heard many proposals. I heard your openness to innovation, even go to difficult pilot studies with tandem biopsies here. You opened our mind to look at certain diseases that were not prioritized here but represent opportunities. We talked about biliary cancer. You pointed out esophageal cancer. I learned, for instance, that there are clearly differences in histology between the West and the East. So for us, it was very, very productive. We took notes. We have a lot to think about this, and what I would wish is that we continue this dialogue on an individual basis and then have concrete actions in Asia, but especially here in China. And I felt very privileged that we were so nicely welcomed here as coming from the West. It was my first experience in this particular setting, a very good one. So thank you all. Thank you for coming. Thank you for your suggestions that we will take very serious and follow up with you.
So before I hand over to Mark Horn, our Managing Director at Merck Biopharma here in China, I also would like to thank you for your contribution. We have now more or less 6 hours worked hard on the different topics. So with a very brief break in between. And I'm looking forward to have further discussions in the future. So I believe, as I started at the beginning, that there is a need to have a constant discussion also here in Asia. That's why we have now this position here. I'm happy to talk anytime in close collaboration with our other hubs in Darmstadt and Beda-Rica. All of them are now here. So we really want to move forward to bring products also here to Asia. Thank you very much for your contribution. And now I hand over to you, Mark, to give some closing remarks, please.
I keep it very short. I found it very exciting that you all were here. Thanks a lot for your valuable time to come together here, especially on a weekend. I've been now in Asia for the last 15 years, and for me, it's always been important that we raise the voice of Asia in the global context. And because we have huge population here, we have huge needs here which are partially different from what you see globally. And we have a huge expertise and talent pool also here to contribute overall. And I think what you see in many of the countries here you're representing, and especially in China, also from the government side, a lot is happening now to improve access to health, be it on the regulatory side, but also in the way with various stakeholders interact with each other. And so for us, this kind of forum for the first time here, it's really a privilege and something we would like to continue doing going forward, to really learn from each other, listen and learn, and can take that back to our global organization as well, and really bring in the particularities of each of your countries into the studies. And I strongly believe, we see that also on the commercial side, with this regional setting we have now, the interaction between the different countries and the expertise we have in different countries will really add value based on the experiences each of you has individually. And from that side, I'm really excited to be here, and thanks again for your time.
Thank you.